Good morning, everyone. I see everybody's starting to join, so I will give everybody a minute here. The numbers are steadily increasing, so I'll give everybody some time here. Just while we are waiting for everyone to join the session, just a few housekeeping details. I know Jenna may have mentioned these in the welcome session that you guys all just hopefully attended as well. But for all the sessions moving forward, the chat will be open for questions. There should be two options here, the Q&A and the chat function. All the questions will be held till the end though. So if you have any questions throughout, please just enter them in and I will be sure to be asking Dr. Coffey at the end of the presentation here. The session is being recorded as well. They will be posted on the platform for 30 days afterwards, as well as on the SPCNY website. CEUs and CMEs are being provided as well. More information, an email will be sent out with an evaluation survey and confirmation of attendance will be sent out after the symposium. So again, stay tuned for that. And again, if you have any questions, please feel free to enter them in the chat. I will hop right into an introduction here. Again, good morning, everybody. Thank you for joining us. We have Dr. Edward Coffey here presenting at this 9 a.m. session. Dr. Ed Coffey is a neuropsychiatrist, a healthcare leadership advisor, and an affiliate professor of psychiatry and behavioral sciences at the Medical University of South Carolina in Charleston. He earned his medical degree from Duke University in 1979, where he subsequently completed a medical internship and residencies in neurology and psychiatry. Dr. Coffey has held faculty and leadership positions at Duke University Medical Center, Allegheny University of the Health Sciences, Henry Ford Health System, and the Menninger Clinic. Dr. Coffey is an accomplished physician, board certified in both neurology and psychiatry, with expertise in neuropsychiatry and brain stimulation, garnering numerous listings as a top doctor. He is also an award-winning healthcare executive, recognized for creating and leading high-value healthcare systems. Dr. Coffey's innovative work on perfect depression care has been widely cited as a model for healthcare transformation, and its audacious goal of zero suicides has become an international movement honored by the Joint Commission, the American Psychiatric Association, and the Malcolm Baldrige National Quality Award, as well as by his appointment to the National Action Alliance for Suicide Prevention in 2011. Today, we are honored to have Dr. Ed Coffey here to present on Vision Zero, Eliminating Suicide and Transforming Healthcare. Thank you, Dr. Coffey, for being here today.
Oh, thank you, Kara, very much for that nice introduction. And good morning, ladies. It's a real pleasure to be with all of you here today. And could I just begin by sending a big shout out to Jenna and Kara and the entire team at the Suicide Prevention Center for putting together a fantastic symposium. I am very pleased of this three-day journey, three-day adventure, and I look forward to learning with you. So let's get started. The goal of my presentation is to introduce you to the notion of Vision Zero, and how applying this concept, how pursuing perfection might result eventually in achieving excellence, paraphrase Coach Vince Lombardi. So my presentation will begin with an overview of the suicide crisis in this country, but we won't dwell too long on that matter. We'll transition fairly quickly into a model that has increasing evidence for efficacy. This is the zero suicide model. I'll say a bit about its origin at Henry Ford, how we began to facilitate and spread that model with big help from the state of New York and its inhabitants and leaders, and share with you some early results from the early adopters. And then lastly, we'll talk about how applying this concept to zero could result not only in improved suicide care, but in care for all of our sex. I have no conflicts of interest to disclose, and I believe these slides are available to you somewhere within the website. We'll ask perhaps Carl or Jenna to point that out to us at some point later today. So these numbers, I think, are likely familiar to all of you. We have a real crisis in this country with regard to suicide rates. As you can see here, the rates have been going up steadily past 20 years to the point now where we're at 35% higher than we were back in 1999. This is true, of course, for men and for women, as you see here. There is substantial regional variation in these rates. As you can see from this slide, the rates are highest in the Mountain West states and in Alaska. We're hearing a bit about this in our symposium over the next several days. I do note that my state of South Carolina is not doing very well, but you folks are doing quite well. I think your rates, at least through 2019, were 8 per 100,000 or so. I point this out because on the one hand, you could say, hey, we're the best in the country. Then you could pat yourself on the back and move on to the next chapter. But instead, you've embraced this idea that even one suicide is too many. We want to do better. So I think that's pretty special. And I just want to thank you for that approach and for, again, putting together such an exciting symposium today. Now, we want to transition to this notion of Vision Zero and zero suicide. How in the world did this thing ever get started? How is it even possible that anyone would think that we could eliminate suicide? The concept of zero suicide emerged from 3 seminal events back in 2001. The first was the publication by the Institute of Medicine of its Quality Chasm report. The second was a response to that publication from the Robert Wood Johnson Foundation and Institute for Healthcare Improvement, known as the Human Perfection Project. And the third essential element was the Perfect Depression Care Initiative at the Henry Ford Health System in Detroit that I led for 14 years. Let's take a look at each of these events in turn. So in 2001, the Institute of Medicine published what I consider to be the most important document in healthcare this century. I hope that many of you with it. I hope that if you haven't read it, you'll get a chance to. It's not highly technical, but it's profoundly important. It's important not only for its criticisms of our healthcare, but also for its description of a potential path forward. I'm going to Cliff Notes version of the report now. So the report begins with appreciating and recognizing the incredible, hardworking healthcare in our country. The doctors, the nurses, the frontline staff, highly educated, highly dedicated, work very, very hard. Even clearer during this time of the pandemic, of course. In addition to this great workforce, we have tremendous scientific enterprise in this country. What we've learned about health and wellness over the past many decades is incredible, and our scientific enterprise is really exceptional. So that's the good news. The bad news is that despite people and despite increasing knowledge from our great science, the healthcare that people are getting at the bedside is mediocre at best. Now, remember, this criticism is not coming from a fringe group. This book was authored by the thought leaders in international healthcare. And it's our thought leaders that were saying back in 2001 that our system is broken. And furthermore, it is so badly broken that we're not going to fix it by tweaking at the margins. We need to basically tear it up and start over. Now, lest you think that the criticism is outdated. Here we are 20 years later, and we have the publication from the Commonwealth Fund of its updated comparison of the 11 high-income countries in the world. And you can see here in this table that the United States ranks dead last among these healthcare, in healthcare, among these 11 well-developed, high-income countries. You can refer to the document here to look at how each of these dimensions of assessment were measured, but board, we do very poorly. And because our healthcare is so expensive, consuming 17% of our gross domestic product, the value of our care, that is the quality that we get for the money that we spend, is very, very low and dramatically lower in the other 10 countries that you see here. So although the Chasm report was written in 20 years ago and it bemoaned our healthcare system then, the unfortunate news is that problems persist. Now, what makes this report so exceptional in my mind is that it didn't stop with just a criticism of our healthcare system. It went on to describe a potential path forward. And part of that path forward was a definition or a conceptualization of what ideal healthcare might look like. The report defined 6 dimensions of ideal. For care to be ideal, it must be safe. We shouldn't hurt people when we try to treat them. Second, the care should be effective. It should work. We should use things that work, and we should not use things that don't work. And I would ask any of you in the audience today to reflect on whether you think we do that today. Do we ever do things in health that we know might not be effective? Or do we hold back treatments that we know could be effective? You're driving the car. I might be in the front seat with you. I might be navigate your healthcare, but you're in charge of your healthcare. The care should be timely. We shouldn't waste anyone's time. And you might reflect for a moment, has your time and lastly, it should be equitable. I stress this last metric because here we are 20 years later, discussing the issue of equitable healthcare. But 20 years ago, this issue was called out by the Institute of Medicine in the Chasm report as an essential element in the concept of quality. We might also just pause here for a moment and reflect about whether our teams back in our respective departments and clinics, do we have an understanding? Do we have a shared understanding of what healthcare quality looks like? If we interviewed each of our teammates, would we be able to describe what we mean by healthcare quality? Do we have a model for quality? And or do we have any idea how we might be doing, how we are performing on those dimensions of ideal care? The Chasm report went on also to list 10 rules for designing a new healthcare system that would lead to ideal care. And I particularly like the first rule: care is a relationship. It's not a visit to the office. It's not a hospitalization. It's not an email. It's not a telehealth visit. It is a relationship. It's customized and it's centered on the patient and the family. They have the car keys. Providers share knowledge. What a unique idea here. We're going to actually work with each other and share information. We manage by fact. As was mentioned earlier, we don't do things that don't work. We engineer our systems to make safety a priority. We embrace transparency, Everything that we do is out in the open. At several of my previous locations, I have spearheaded initiatives to open up the medical record so that patients and their families have full access to every document in the medical record. Imagine, full transparency. The system should be anticipatory. We don't wait to react to something that goes wrong. We anticipate patient needs and act accordingly. We have to be efficient. We have to continually reduce waste. We're spending way too much money. You saw the slide earlier. We're spending way too much money on healthcare in this country for the quality that it produces. So we've got to find ways to continually lower our cost, to remove that waste and make the healthcare more affordable. And lastly, physicians and professionals need to cooperate. So when the Chasm report was published, the Robert Wood Johnson Foundation, a large philanthropic organization in this country, became very excited about the possibilities of pursuing and developing an ideal healthcare system. And so in partnership with the Institute for Healthcare Improvement, the RWJF launched a national collaborative Pursuing Perfection project. And the idea here was that if there are organizations out in the country that take the Chasm report and use it as a roadmap or as a model for transforming their care system, the foundation would give you a few $1 million to help get that process started. This collaborative was coordinated by the Institute for Healthcare Improvement and Don Burrick, a name I'm sure that's familiar to all of you. So the notion here was achieving perfect very rapidly. It's taken us way too long to bring about improvements in healthcare. It takes decades and decades, it seems, to make even minor changes. And so the Robert Wood Johnson Foundation and IHI both recognized that we have to get better, and we have to get better quickly. So when the RFP was released, about 3,000 applications were downloaded. Once people saw that you had to get better in 2 years, not quite as many were as excited about the project as maybe they were at first blush. But there were approximately 300 applications submitted. 25 semifinalists were selected, and 12 finalists made it to the penultimate decision point. And our project at Henry Ford Health System, known as Perfect Depression Care, was one of those finalists. It was, interestingly, the project that focused on mental health care among the 12 applicants. So why was the project called Pursuing Perfection? What is important about this notion of perfection? Well, here's some interesting statistics that were released at the time. I believe that might still be semi-appropriate, but they make the point. If 99.9% accuracy is good enough, then 2 million records will be lost by the IRS this year. If 99.9% accuracy is good enough, 12 babies will be given to the wrong parents this year in this country by the hospital. 18,000 pieces of mail will be mishandled in the next hour. Now, I don't think there's that much mail flowing anymore through the Postal Service, but back in 2001, that was the estimate. And then finally, if 99.9% accuracy is good enough, 2 landings at your LaGuardia Airport will be unsafe today. So we've got to do better. 99% is not good enough. We have to be reaching, we have to be striving for perfection. I go back to this notion of being the best. We see this commonly in our system is the best at X, Y, and Z. But as one of my friends said, that really is nothing more than the cream of the crop. Basically, his point is, what does it mean to be the best in a mediocre industry. Being the best isn't good enough. We've got to pursue perfection. And that was the concept in the collaborative project. So just a word about the test tube in which our work was done, the Henry Ford Health System. It's a very large, vertically integrated healthcare system in the US, based in Detroit, but hospitals and clinics throughout the Midwest region. It's about a $3 billion company. It's approaching 30,000 employees, numerous hospitals, numerous clinics, its own medical group, the Henry Ford Medical Group, and it owns and operates its own insurance company, which in turn HMO. That HMO was the test tube in which work I'm going to show you was conducted. It really does strive to be a learning organization. It's very focused on continually improving quality. And I'm very pleased to say that while I was there, the Malcolm Baldrige National Quality Award in 2011. And I'm especially proud to say that the recognition was based in part on the innovations that we created with our Perfect Depression Care initiative. Within the Henry Ford, mental health care is organized in a service line called Behavioral Health Services. And we had responsibility for providing the mental health care to all of the patients who visited, whether they were in our HMO, whether they were insured by our insurance company, or whether they were just seeing us as traditional fee-for-service Medicaid activity. So in many ways, behavioral health services, our mental health line, was a system within a system. And it provided a great opportunity to test this notion of pursuing perfection. So the strategy for the Perfect Depression Care Initiative was to identify perfection goals for each of those 6 dimensions of quality care: for safety, for effectiveness, for patient-centeredness, and so on. The idea then was to measure where we were currently compared to what that perfection goal looked like, and then to cut that in half, to cut that gap in half over the next 9 to 12 months. Remember, we want to do this improvement rapidly. At the end of that 9 to 12 months, we assess where we are, we measure where we are, and then we commit to cutting that remaining gap in half over the next interval, over the next 9 to 12 months. So define what perfection would look like, and then cut that goal in half over a very short period of time. So here are the goals that we set out for ourselves with regard to each of these dimensions. Looking first at safe care, we decided that perfection would be the elimination of falls among our inpatients and the elimination of medication errors. Not a reduction in medication errors, not having the best rate of medication errors in the region, but having 0 medication errors. If you come to Henry Ford, you will not experience an error in your medication. These other dimensions, patient-centered care, timely, efficient, and equitable, we basically defined as 100% complete satisfaction. And we asked the patients on a regular basis how satisfied they were with these aspects of care. I'll be returning to that issue in a moment. But the point was that for many of these items, tools did not exist for real-time measurement of performance on that dimension. So we had to make our own tools and put those in place. Again, I'll worry about those in a minute. You can see here that the definition of perfectly effective depression care is blank. This is because we had a great deal of difficulty coming up with what we thought was really an audacious enough definition of perfectly effective care. Initially, we thought that we would do just what the pharmaceutical company basically commit to, having a 50% or 60% reduction in depression scale scores, the Montgomery-Åsberg, let's say, score, within some period of time. But that really did not generate the traction that we were looking for. And in fact, in an early draft of our proposal, the feedback we got from Dr. Burton was that simply lowering depression care scores was what they had in mind with regard to perfect depression. So we went back to the drawing board. We had numerous focus groups and breakout groups involving every employee in our department, our customers in the community, other people from the community who were committed to improving mental health care for the greater Detroit area. And eventually one day, one of our nurses raised her hand and said, well, I guess that if we were doing truly effective depression care, nobody would kill themselves. No one would die from suicide. And I'm pausing here for a moment because I'm getting goosebumps like I always do when I mention this. And also because the self went deadly quiet when she made that suggestion. It was as if people had asked for air. And after what seemed like several minutes, one of our senior clinicians spoke up and said, well, that's crazy. Obviously, if somebody wants to hurt themselves, we can't possibly stop that. This is crazy. Do this. And that question, long conversation, which in turn transformed our department. On the one hand, we acknowledged that, as this physician just said, it might be impossible to eliminate suicide in every case, particularly if an individual really, really, really wants to do it. But given that, what goal be? What number of suicides are we going to tolerate? Are we going to expand our department? Is 12 suicides a year the right number? Is that number in your parent or my sister? We realized that the only answer to this question is 0. Our goal has to be 0. And at that moment, our department was transformed. We stopped trying to be the best. We stopped trying to improve incrementally, and we began to strive for perfection in all of our goals. Now, eliminating suicides here is in red font because it was so crazy. It was so audacious that it kind of transcended all of the other goals. And it lifted, the energy it created lifted our performance in all of these areas. It was truly amazing. And, made the point very early that there is magic in this notion of vision 0. Now, I want to just say a word here about the importance of culture. Perception is only possible if you have a just culture. And by just culture, culture in which mistakes and errors are viewed as system issues, not personal failings. Errors are viewed as opportunities for learning and for improving the system, not punishing people. That sounds simple, but it's profoundly important. We can't ask our teammates to go up to the plate and try to hit a home run every time and then turn right around and punish them for striking out. That's the concept here. Our teammates don't get up in the morning and go to work with the goal of making a mistake. They go to work with the goal of being perfect. And when mistakes happen, most of the time, they are a result of system errors. I think you'll hear Mike Hogan talk a bit more about this a little bit later today. It's bad systems that tend to create these errors, not bad people. So you're not going to be successful at attempting to put in place a Vision Zero type model if you can't also at the same time develop and maintain a just culture. And I stress the latter issue, maintenance. It's one thing to get it started, but you've got to do this every day. As a leader, you've got to walk this walk every day. You can't just talk the talk. We far as remove the request for a name of an individual from our instant reviews. We didn't ask who did it. We asked what happened. So we could spend an entire day on this notion of just culture, but I just want to stress the fact that it's one thing to set perfection goals. It's equally important to create the culture in which setting those goals and pursuing them can happen. So the model that we used to try and achieve these was what we call the planned care model. It really it was based on Ed Wagner's chronic care model. And if you Google chronic care model or Ed Wagner, you'll find tons of resources that will help you put in place a similar kind of design. And the basic notion of the planned care model is that what you're trying to create is improved outcomes, improved clinical outcomes. And to do so, you need an informed, activated patient interacting with a proactive practice team. And if you can create that dynamic, that dyad, then the result will be an improved outcome. And so everything upstream from your community resources to the way you've organized your health system is focused on creating productive interactions, self-management support. So the patient has a need to take care of their health. And furthermore, they're activated, they're engaged in their care. On our side, on the practice team, we have a delivery system design that makes this interaction possible. Patients get the care they want and need whenever they want to need it. And clinicians have everything at their fingertips to make the proper decisions to advance the care of their patient. Now, what I like about the model is that it lines up pretty well with those dimensions of ideal care that we saw described at the Chasm report. So for example, patient-centered, timely, efficient, and equitable care lines up well with the notion of an informed, activated patient. And similarly, safe, evidence-based, effective care and coordinated care line up well with having prepared, proactive practice teams. So this was the model that we used to begin to redesign, to transform our healthcare system. So how do we do? In the next few graphs, I'm going to show you the rate of suicide per 100,000 patients. This is the way suicide rates are typically described. The maps I showed you earlier used this metric. And for reference, I'm going to sort of establish where the goalposts are first. So here at the bottom is the rate of suicide per 100,000 population in the state of Michigan during the time that we began and carried out the Perfect Depression Care Initiative. That number is about 11. You may be able to see that it was slowly increasing over time. And as you saw earlier, going forward, it has continued to increase. So in the background population, the rate is going up. Now, for reference, what is the rate of suicide in patients with depression? It's as much as 20 times higher than the general population, 20 times higher. Now, an important point here is that this elevated rate of suicide is not limited to just people with depression. Every major mental disorder, not just the mood disorders, the thought disorders, the anxiety disorders, certainly if they're comorbid with substance abuse. All of those disorders carry about the same elevated rate of suicide. My point here is that if you're going to put in place a suicide prevention protocol, you can't limit that protocol to a focus on people with just mood disorders. It really needs to apply to your entire health care system or organization. And by the way, should it be limited to just those patients in mental health care? Shouldn't every person in the healthcare system have some kind of suicide safety plan in place? More about that later. Now, here's something that I'm somewhat embarrassed to tell you I didn't know at the time, or if I'd ever learned it, I'd forgotten it. What if your patients with depression have been treated and their mood disorder is now in remission? What is their risk of suicide? Is it back here to baseline? It actually remains elevated somewhere between 4 and 10-fold. If your depression is in remission, as a group, you're still 4 to 10 times higher risk of suicide. Now, what do you think we were doing at Henry Ford back in 1999 to prevent suicide in patients whose depression was in remission? Exactly. So we had work to do. We obtained data for the 2 years prior to the launch of our project, our initiative. And remember, these are patients in an HMO. So while we applied the system care improvements to every patient that we saw, the measurements we took were in our HMO. We did that because since we had full responsibility, patients, these 200, 500,000 individuals, we knew not only the numerator, we knew what happened to that individual if they died and if they died by suicide, but we also had a denominator, the size of our HMO population. And that allowed us to calculate the rates that you see here. So at baseline, the rate was somewhere between 105 and let's say 80 or 90. So we took about 90 as our assumed baseline rate. In 2010, we launched our Perfect Depression Care Initiative. And as you will see, over the ensuing 10 years, we had a dramatic reduction in suicide rates. In fact, for 18 months, we actually accomplished 0 suicides. They said it couldn't be done. We did it. And the average of this reduction over the period of study, was around 80% in reduced suicide rates. To this day, still the most dramatic evidence for suicide reduction in a healthcare organization. So we're often asked, how did we accomplish that reduction? What was the secret sauce, if you will? And I have to say that I can't give you an evidence-based answer to that question. Ours, of course, was not a controlled experiment. The Perfect Depression Care Initiative was not controlled research. It was quality improvement research. We were doing lots of things at one time to try and improve very, very quickly. Now, that said, our team had a lot of experience with what was going on and a lot of ideas about what accounted for the improvement. We did everything we could to improve our system so that we provided rapid access to diagnosis and treatment. So we got people to treatment quickly. Their mood disorder, their thought disorder, their anxiety disorder was assessed and treated as quickly as we possibly. But this next one, I think, perhaps was the biggest lever for us. What we called at the time means restriction, and now goes by a broader term of safety planning. We made it very, very clear to patients and their families that the most important thing they could do and we could do was to make it hard for the individual to carry out the suicidal act, to buy time between when impulse bubbles to the top of consciousness and then when it finally recedes. So we got very good at having conversations around safety planning and means restriction. You're going to have to measure how you're doing. And we had almost none of these systems in place. You'll be hearing later from Brian Amadani about the importance of data management in this kind of. And again, somewhat embarrassingly, I stressed the importance of asking the patient and family. If we want to know how we're doing, why don't we ask the customer? And by the way, let's don't ask them on a that gets mailed out 6 months after the appointment or after the hospitalization, and we receive months later. How in the world are we going to address a real-time issue in quality if we're not even asking people until sometime after the encounter? It's like the hotel asking you about your night's stay 6 months later. How was the pillow? Well, the pillow was terrible. I wish you had asked me when I was there so I could have gotten a better pillow. So we've got to change the way we do these things. And in that regard, I wanted just to share with you briefly here a tool that we developed called the Assessment of Care. We described it in a number of publications, as you see here. And this tool essentially, this is the paper version, the early version, but it's now electronic. It can be electronic. And basically, we took the 6 dimensions of perfect care, as you see here, and at every encounter with our patients, we asked them, how safe is your care? And the answer was indicated by a mark on this line, which is exactly 100 millimeters long. So you could put a ruler on it and you can measure the score, if you will. And anything that is less than 90, a score of 90 millimeters for the left side, we took as an indication that the patient was not completely satisfied. And when we saw such a score in real time, we stopped the work. We pulled the cord, as they do on the Toyota assembly line, tried to address that issue for that patient at that very moment. This is a profoundly important tool. It generates incredible insights into the person's experience of the care and incredible opportunities for improvement. This notion of equity, by the way, we were into some time ago, and it is profound. Imagine asking every one of your patients and their families, every time you see them, do you believe that your care, that we treated you fairly today? Have you seen us treat anyone else unfairly? We want to know about this because it's not who we are. It's not what we want to do. If you see it, let us know. We want to fix it. If you want to address equity, this is a really, really superb way, an immediate way that you can start correcting inequities immediately. And are there inequities in suicide care and in suicide crisis? You bet you. Here's the general population. Here is the non-Hispanic American Indian and Alaska Native, as well as the non-Hispanic white. So these groups have much higher rates of suicide than do the other groups, other racial and ethnic groups. Although in all groups, the rates are going up. Okay, so once we began to generate these data and began to show that it was possible to dramatically reduce suicide rates, it was important to share that learning, the information out there, so others could begin to evaluate it, decide what works, what doesn't work, and begin to the nuances of the protocol through more rigorous types of experimentation. I can't stress again how important it is for you to not only do your improvement work, but then capture the learning and describe it. Don Berwick has always said that an improvement project is never over until the results have been published. Really, really important to do that. And once we got the publications going, we began to get recognition from a number of organizations. The most critical recognition was from Mike Hogan and David Covington when they were leading the US National Strategy Update. I still remember the day when David gave me a call and said, hey, we'd like to talk to you about this crazy idea of zero suicide and how it might fit into the national strategy. I'm sure Mike and David will be saying more about that later. But to make a long story short, it became part of the national strategy. And then through the tremendous work that Julie Goldstein Grummet and Rich McKeon have done in creating the SAMHSA-funded Suicide Prevention Resource Center, it's now possible for organizations across the world to begin to adopt this zero suicide model and begin to put those improvements into place. Mike helped to systematize the model, and then Julie and Rich and the Suicide Prevention make it possible to pick it up. And then lastly, of course, this thing has gone viral. It's now an international movement, thanks in no small part to the work of David Covington and many others, and Malkinstorm, Joe Rafferty at Mercy Healthcare in Great Britain, Sue Murray and Catherine Turner down in Australia, and many, many others. Page forward for the work moving from an improvement project to an international movement. So what is the outcome? What have been the results of this work? Importantly, we have begun to set goals. This sounds kind of basic, but for a long time, we didn't have goals in this country or the world. We wanted to lower suicide. We wanted to make it better, but we didn't have goals. We didn't commit to specific targets for reduction. That has now changed. And across the world, from the United Kingdom to here in the US, goals have been set for suicide reduction. You might argue that maybe a goal is not aggressive enough, but it's a goal. And so we're going to declare victory, at least at this point, and move forward. In addition, there's been a call for improved performance standards. Organizations such as the Council on Accreditation, NAASP, the Joint Commission, CARF, all of these organizations have begun to ratchet up the standards which they consider to be essential for good suicide care. So this has been an important improvement in our opportunity to end suicide. At last estimate, there are maybe 1,000 or more organizations that have begun to adopt some aspect of zero suicide, the zero suicide model. And a number of these organizations, not enough, but some are beginning to describe their results. Again, the importance I mentioned earlier of capturing the learning and then publishing that information. All of us can learn and then add that learning to our improvement. But there are reports now that data validity and monitoring are much improved with this model. Screening rates for suicide have improved dramatically in a number of organizations. Safety planning, you guys here in New York, Verna Little, have played an important role in improving the spread and application of good safety planning for all of our patients. Follow-up appointments, very, very important. We know that handoff period is very critical as a risk time for suicide. Reduced admissions and related costs have been achieved in our Native American populations through the use of the zero suicide model. And a focus on culture and a better understanding of how one can obtain a just culture or restorative culture. A lot of this work has been led by Catherine Turner and her group in Australia. In addition to process outcomes, we've had great clinical outcomes, although again, the data are just beginning to trickle in. But here are 3 important findings, hot off the press. At Centerstone in Tennessee, Becky Stoll has reported that among a group of 140,000 patients in community-based MHCs, when she implemented their zero suicide protocol, they saw a 57 to 64% reduction in the annual rate of suicide over the ensuing 2 years. There were 2 cohorts that they followed, but those numbers are not too far off from the 80% that we saw at Henry Ford. So a very, very interesting signal. I'm looking forward to Becky's publication of those results. In Australia, again, Catherine Turner and her group have a very large public health system, 560,000 patients. And in that group, they followed 604 of those individuals who had experienced at least one suicide attempt in a 6-month period. And they observed that those that were placed on the zero suicide protocol had a 65% reduction in suicide attempts over the next 90 days. Again, numbers that are in line with what Becky saw and what we have reported at Henry Ford. And then here in your own New York State system, you did a baseline, you recently published the results of a baseline observation where you found that those MHCs that were participating voluntarily in a statewide zero suicide project, those with greater fidelity as measured by a self-assessment scale, greater fidelity to the zero suicide model, had experienced fewer suicides in the prior year. So those that were already doing some of this work were already beginning to see a reduction in their suicide rates. So this thing appears to work. You can make a difference. You can bend the curve. The critical question that you're going to have going forward is not just do we sign on to zero suicide, but what are we signing on to? What exactly are we going to do? I think a number of organizations are perhaps not embracing the entire model, or at least not the model for innovation that we developed here back at Henry. That model consisted of 3 essential elements that you see here. The first was, as you see at the base of the pyramid, was a radical conviction that ideal healthcare is attainable. Do we really believe that we can eliminate suicide? Do we believe it? And are we willing to commit ourselves to that goal? This sounds basic. And in fact, when I give this talk to a lay audience, I often get questions at the end like, you mean you guys don't believe that you can prevent suicide? What are you doing if you don't believe that you can prevent suicide? How is that possible? The lay public becomes incredulous when they realize that maybe some of us don't believe this. And furthermore, many of us were taught that it's not possible to prevent suicide in every patient. Today, there's still a great controversy about this. People continue to write articles challenging this notion of Vision Zero, and in fact, suggesting that it might be harmful. So can we sign on to this radical conviction? Next, you need a roadmap. And that roadmap in our case was this notion of pursuing perfection, this Vision Zero, in a just culture. The former is not possible without the latter. And then thirdly, every teammate needs to become an expert in systems engineering. Our work is about improving processes. And to be able to do that, all of us have to understand processes, expert in the word process improvement. So I'm sure we'll have a chance to talk more about this, this pyramid and this decision that you'll be making over the course of the next few days. But I'm again, very, very pleased to have been here with you today. I'm excited that you're thinking about this journey, and I'm looking forward to being a part of this journey and helping you in any way that I possibly can. Good luck and have a great 3-day symposium. Thank you.
Thank you so much, Dr. Coffey. I think we have 1 or 2 minutes for any questions. So if you'd like to enter those into the Q&A area, feel free to do so. I do want to leave a few minutes at the end so you guys can hop on the next session. That will be with Dr. Ed Boudreau. Sarah asks, or she would like to hear some more information about a just culture. Is there anywhere they can find some more information around that?
Yes. One of the best documents on this matter was recently published by Catherine Turner. And so if we go back to the slide, let me see if I can get us there. Oh, here we go. Just Google Catherine Turner and look at her publications over the last couple of years. She's done some brilliant work on this notion of what she's calling a restorative culture. It's similar to the concept that I use of just culture. And it'll go into the key elements of that culture and the strategies that one would need to use to develop such a culture. But essentially, it's the notion don't blame people for errors in the healthcare system, because most of the time, those errors are not people behaving badly. They are systems not performing appropriately. And so it doesn't make sense to blame a person for a system error. And furthermore, doing so has harmful effects on your culture. So I'll direct you to Catherine Turner's publications for more information.
Great. And do you think there will ever be a perfect healthcare system? Over time, Precious feels that mental health will change from symptoms to cures. So how will we be able to keep it perfect?
Well, that's a great question. I do not mean to minimize the challenges that we have in mental health care. Our science, while very good, is a long way from providing a complete understanding of mental health and mental illness in turn. And we have a lot of work to do around the treatment and care of individuals with mental health problems. But that said, there's no reason why we can't begin the work. This is sort of the notion of not letting the perfect get in the way of the good, right? We can get started. We can strive for perfection. And as again, Vince Lombardi said, hopefully we'll end up with excellence. And that's kind of my approach to this whole thing. It's interesting that in many cases, we've criticized this notion of perfection, haven't really provided an option, for other steps. So I think it's powerful. I think it can energize your team like you wouldn't believe. And it can cause you to think about your system and your approach to care in ways that you would never have imagined if your goal had simply been to get better.
And one last question for the sake of time. Any advice on how to get non-behavioral health leadership and C-suite on board for this work?
Very important question. Leadership involvement is essential to the success of this kind of work. This cannot be the flavor of the month. It can't be the quality improvement project of the month. It has to be a system-wide initiative. And I think the approach that you take with your leadership will depend in part on what kind of system you're in and how that system is managing mental health care. Perhaps we could talk a bit more about this at the Q&A session this afternoon.
Yes. Yes, so if you have any other questions for Dr. Coffey, we will have the panel presentation that will be happening at noon today. So please join in on that. And it is 10 o'clock right on the dot. So please make sure you are jumping onto the next session that will be with, again, Dr. Ed Boudreau. Thank you again, Dr. Coffey.
Thank you.